So we'll move on to the next session, pediatric endocrinology. Under this session, we have 3 topics. So the first topic is approach to the child with mild TSH elevation by Dr. Sivan Arul Selvan. Before starting up the topic, I would like to invite the chairperson onto the stage, Dr. Kumaravel, Dr. R. Ramalingam, and Dr. Sampath. May I request the chairperson, Dr. R. Ramalingam and Dr. Sampath, onto the stage. Dr. Sivan Arul Selvan.
I thank the organizing secretary for giving me this opportunity. The topic is mild elevation of TSH. My only request to the pediatrician is try to work up as much as you can. You are not able to come to a conclusion, you send it to the endocrinologist. Don't start treatment and send to them. They are very difficult to diagnose and work up also then. With this request, I'll ask Sivan Arul Selvan to proceed.
Thank you, Chairperson. The next 20 minutes, I will briefly discuss about how to approach a child with mild TSH elevation. So, what is mild TSH elevation? So, generally we know what is subclinical hypothyroidism. Subclinical hypothyroidism is nothing but any patient, it's a biochemical diagnosis basically. It's elevated TSH with normal free T4. So, it is nothing but a little bit lazy thyroid. It needs more TSH, more stimulation to produce the normal function. So, most of the consensus agree that if the TSH is more than 10, and in the situations there is agreement to treat the patient even though the free T4 is normal. But the lack of consensus is for the TSH between 4.5 or 5 to 10. So, what to do in that situation? That is where there is no consensus. So, that is what I am going to talk about. So, the mild TSH elevation can be taken as TSH values between 4.5 to 10 or whatever is the upper limit of lab normal to up to 10. So, more than 10 generally there is agreement to treat. So, TSH of 5 to 10 we will take it as mild TSH elevation, or otherwise we can call this mild subclinical hypothyroidism. Subclinical hypothyroidism itself is a mild disease, of which mild elevation we can call it, just for the sake of further argument, as mild subclinical hypothyroidism. And you should make sure that the T4 is normal before making a diagnosis of mild TSH elevation, because the free T4 is low or high, that is not mild TSH elevation. That could be central hypothyroidism or TSH producing toxic adenoma, etc. So, what is the problem in diagnosis? First of all, there is no agreement between the reference range in children. Generally, we follow the lab reference range, but there are some articles saying that the reference range differs for each age group. And different labs give different upper limits, so how to diagnose, and there are some variations with the timing and timing of food, etc. So, this can change the TSH values every time you check a patient. So, this is the brief outline. How common is this mild TSH elevation, and what happens if you don't treat? What is the natural history? What are the different reasons for TSH elevation? And is not treating the patient is going to harm the patient? And if you treat, is there any benefit? And if you treat, is there any adverse effects? And finally, what to do in a clinical situation? So, what is the natural history of subclinical hypothyroidism? As you know, that there can be only 3 possible outcomes. Either the subclinical hypothyroidism proceeds to overt hypothyroidism, that is T4 becomes low, or the subclinical hypothyroidism remains stable as subclinical hypothyroidism, there is no change, or it reverts back to normal. So, these are the 3 possible outcomes in a patient with subclinical hypothyroidism. So, how common is these 3 outcomes? Which is the most common? So, what the data says about the natural history? First of all, there is scarcity of data, especially in children. Most of the studies are retrospective, so we cannot say with confidence what happens in a patient. And most of the studies, the sample size is very small. Except for 2 or 3 studies, most of the sample size is less than 100, 30, 40 like that. So, that is also a difficulty in correctly assessing natural history. And follow-up duration is variable, starting from few weeks to up to 9 years. And the cutoff used, TSH cutoff used, is variable in different studies. between 3 to 6. They have taken the definition of subclinical hypothyroidism with different TSH cutoffs. So it is difficult to conclude, but these are the several studies. This article was published by Dr. Sriram in Indian Journal of Pediatrics. I've just briefly summarized the findings in the next 2 slides. As you can see, except for 2 studies, most of the subjects are less than 100. So small sample size, and the follow-up duration is between 2 to 9 years. So what is the chances of progressing to overt hypothyroidism? Or some studies have taken as TSH more than 10. So as you see, the progression to overt hypothyroidism is very, very less. It ranges from 0% to up to 12 to 13%. So the chances of overt hypothyroidism is very less when the TSH is mildly elevated. So what are the chances of TSH normalizing when you check the patient after 6 months or 1 year? The chances are quite high. At least 1/3 of the patients with subclinical hypothyroidism revert back to normal. So if the range of normalization is between 30 to 70%. So there is a very high chance of spontaneous normalization of the patients if you follow up the patient. So in the rest of the patients, the TSH remains mildly elevated. So the most common outcomes are either the subclinical hypothyroidism continues to remain a subclinical hypothyroidism, or they revert back to normal in at least 1/3 of the patients, and the risk of overt hypothyroidism is very low as far as the data is showing. So what is the reasons for this mild elevation? So all causes of primary hypothyroidism can start as subclinical hypothyroidism and progress to overt hypothyroidism. Autoimmune is of course the most common cause. Any cause can cause which cause overt hypothyroidism can cause subclinical hypothyroidism. But why some cases are not progressing to overt hypothyroidism and why some are reverting back to normal? So what are the reasons for that? So these are some of the reasons in which the subclinical hypothyroidism can be temporary and reversible. First is any patient with any acute illness, non-thyroidal illness, then they can have temporary changes in the thyroid axis. During the illness, everything becomes low, and during the recovery, TSH can overshoot above the normal and then reverts back to normal. It is a temporary change. And some patients with subacute thyroiditis or postpartum thyroiditis, TSH is reversibly elevated. And obesity, 1/3 of the obese patients can have elevations of TSH, which again reverts back to normal if the patient loses weight. In Addison's disease, TSH can be elevated up to 20, and it reverts back to normal if you treat Addison's disease. And some of the drugs like antithyroid drugs, iodine-containing drugs, amiodarone, etc., can cause temporary changes in the TSH elevation. And sometimes it could be lab error or timing of the sample or relation to the food. This can also change the TSH levels. And autoimmune thyroiditis is not always progressive. It can be temporary or it can be mild and reversible. At least in pediatric patients, up to 40% of autoimmune thyroiditis can be reversible or non-progressive. And sometimes there is no explanation, there is just a random variation which normalizes by itself the next time. Okay, why some is not progressive and remaining stable as mildly elevated? Why is it not progressing? So these are the possible reasons. As you know, the normal value is taken from the 90% of the normal healthy variance. So 2.5 patients can have low value, 2.5 patients have high values. They are just a statistical problem, euthyroid outliers. And as I said, autoimmune thyroiditis need not always progressive. It can be a mildly stable autoimmune thyroiditis also. And obesity, if they don't lose weight, they can continue to have mild elevation, the TSH. And some mild thyroid abnormalities. All thyroid development abnormalities need not present at the congenital, at the neonatal stage. They can manifest later. Especially mild developmental problems like mild hypoplasia or mild dysgenesis, they can present later as mild TSH elevation, compensated thyroid failure, as call it. And especially in those children with non-autoimmune TSH elevation, a significant proportion of patients are found to have TSH receptor mutation. That it's something like insulin resistance. TSH is having some mild resistance, so it needs a more higher levels of TSH for thyroid stimulation. At least in 20% of non-autoimmune thyroid subclinical hypothyroidism, TSH receptor mutations are noted. And some symptoms like Down syndrome, Williams syndrome, there is a high chance of TSH elevation. Our own paper noted that at least 40 to 50% of small for gestational age can have TSH elevation, which is not replicated in other studies. and sometimes there can be lab interference due to antibodies. So these are some of the causes for reversible or non-progressive TSH elevation. So just a word about TSH in obesity. Up to 20 to 30% of patients with obesity can have mild TSH elevation, and sometimes there can be elevated free T3 also. And this TSH falls when the patient loses weight without any thyroxine replacement. And the general understanding is that the TSH elevation is a consequence rather than the cause of obesity. So there is a linear correlation between the BMI and the TSH. So why TSH is elevated in obesity? These are some of the possible reasons. Leptin can stimulate the pro-TRH, and this TRH can stimulate pituitary to produce more TSH. And other regulators for appetite can also alter the TSH secretion. And there is said to be decreased responsiveness both for the TSH and free T3 in obese patients. Since there is less responsiveness of T3 in the pituitary, there is less negative feedback and TSH can increase. And there is also alteration in the dehydrogenase activity. There is there is more conversion of T4 to T3. That is one possible reason for increase in T3 levels. So the general understanding is that TSH is not the cause for obesity, and the elevated TSH it just reflects the altered energy metabolism in obesity. Okay, what will be the reasons? Is not treating the patient is harmful. So what are we worried about as a practitioner? If I don't treat, anything will happen to the patient. So these are the possible theoretical concerns. For most important concern is how common is progression to overt hypothyroidism. As I already told you, the chances are less. Will the patient become short-statured? Will the patient become more obese? Will the patient have any brain development problems, cognitive deficits? And what will happen to his puberty and cardiovascular disease? So what does the data shows? Untreated subclinical hypothyroidism do not progressively gain weight. The BMI is not different between controlled patients and subclinical hypothyroidism patients, so there is no problem with weight gain, and there is also no problem with short stature. Long-standing subclinical hypothyroidism is not associated with deterioration in the growth velocity and bone maturation, so they don't end up become short-statured. And there is also no problem noticed in the puberty. They enter puberty just like any other normal child, and there have been no major problems in the brain development. IQ test has been normal, and there is no problems in the psychological development. One study noted, a very small study noted a decrease in attention span, which was not replicated in any other studies. So not treating is not going to be harmful in most of the patients. Okay, just for the benefit of doubt, can I treat the patient? Is treatment going to be beneficial for the patient? There are no RCTs, so there are only prospective studies. And most of the studies have found no benefit in treating subclinical hypothyroidism patient, especially the TSH is between 5 to 10. Just because the patient is obese and TSH is mildly elevated, don't expect the patient to become lean if you treat the patient. There is no change in the BMI if you treat the patient or not treat the patient, no benefit in weight loss. And follow-up studies in short stature patient also has shown no significant increase in the growth velocity. Either you treat or don't treat, there is no significant difference in short stature patients in growth velocity. And there are no benefits with regard to the neuropsychological outcomes also. However, there are two studies which have noted a slight increase in the growth velocity, but these children were not actually short. Between those treated and not treated, there is a difference in the growth velocity. But these patients had other comorbidities like type 1 diabetes or other autoimmune disease. So the significance of this findings is not clear. Okay, if I treat, is there any harm to the patient? Usually there are no major adverse effects. However, iatrogenic toxicosis is a possibility if you overload the patient with thyroxine. And once you start treatment, there is increase in the parental anxiety. The parents can become more obsessed with the thyroid problem. Child is suffering from major thyroid disease like that. So unnecessary parental anxiety when you are not sure of the benefit. And obviously, we treat the patient, there will be more frequent lab visits, hospital visits, more expense. And sometimes you assume the subclinical hypothyroidism is the reason for the patient's problem, and you may miss the actual problem. Patient with short stature, you may just think it is due to subclinical hypothyroidism and you start treatment. But the actual disease, actual reason for short stature may be something else. You may miss the actual problem for the symptom. So what to do in a given patient? should I treat or should I not treat? So first is you repeat the test because that can be transient elevation in TSH in many patients. In one of the study, they have shown that if you repeat the test after 1 to 3 months, TSH can be normal in up to 70% of the patient. So don't jump and make a diagnosis of clinical hypothyroidism. Repeat the test at least after 1 to 3 months. During the repeat test, you can add on the thyroid antibodies. And also look for any reversible causes, any recent acute illness, any history of subacute thyroiditis, any Addison's disease, etc., any drug usage. Look for any reversible causes. And also look for the factors which can predict the progression. So a baseline TSH of less than 7.5, there is very, very minimal chance of progression. More than 7.5, there is slightly increased chance of progression. Female gender, grossly elevated thyroid antibodies, presence of other autoimmune diseases like celiac disease, positive family history, and progressive increase in TSH or antibodies when you serially monitor the patient. If the TSH becomes 6, 7, 8, progressive elevation, that can also predict the progression. So look for factors which are present in this patient. So when to treat is a difficult question, but when not to treat is a more easier answer. So when not to treat, the child has TSH 5 to 10, there are no symptoms, no goiter, and no antibodies. So in this situation, definitely there is not much benefit in treating the patient. So when to treat? This is more difficult to answer. As I said in the first slide, the TSH is more than 10, there is general agreement to treat. The TSH is 5 to 10, the child has symptoms of hypothyroidism, you may choose to treat. The patient has significant goiter. 2 studies have shown that thyroid size can decrease with treatment. So if presence of goiter, you may choose to treat. And whether to treat if the child has decreasing growth velocity. As I showed, 2 studies have shown the slight increase in growth velocity. However, before treating a patient with short stature, rule out other causes. There is no other explanation for short stature, and you can just give a trial of thyroxine treatment. The TSH is progressively increasing, you can choose to treat. And many pediatricians and many endocrinologists may give the benefit of doubt and treat the child in the first 3 years of age because brain development is very critical, and for thyroxine is very critical for brain development. So initial 3 years you may choose to treat. Again, there is no agreement, it's an individual decision. And presence of positive antibodies by itself is not an indication for treatment, it is an indication for more frequent follow-up. So these are some of the reasons when you may choose to treat. So if you choose not to treat, how to follow up the patient? So check the TSH at least once in 6 months to once a year. Don't check it every month, that is not going to be useful. Once in 6 months or once a year for the next 2 years. And if the TSH is stable and the thyroid antibodies are negative, we can just keep the patient on clinical follow-up every once a year. The child develops any additional symptoms like goiter or any hypothyroid symptoms, you can repeat the test. Otherwise, just clinical follow-up once a year. If the antibodies are positive, you can keep the patient on follow-up for more frequently or more prolonged period of time. Maybe check thyroid functions once a year for next 3-4 years. So if you treat the patient, how to follow up? First thing is avoid unnecessary medical problems like iatrogenic toxicosis. Don't suppress the TSH. And just because you start the treatment doesn't mean that the treatment is going to be lifelong. You can interrupt the treatment after 1 to 2 years and see it is reversible or not. So if the TSH rises again, you can restart the treatment. So this is the approach proposed by Dr. Sriram et al. In his article. So if the TSH is more than 10, you can choose to treat. If it is less than 10, repeat the test after 1 to 3 months. Maybe at that time you can do it in the early morning sample in the fasting state and rule out other causes like, as I said, obesity, Addison's disease, etc. And look for factors for progression, goiter, female sex, positive antibodies, other autoimmune signs. If the TSH is stable on follow-up, you can just keep the patient on clinical follow-up. The TSH progressively increasing, you can choose to treat. So these are the take-home messages. Mild subclinical hypothyroidism or mild TSH elevation is generally a benign problem. And mild TSH elevation is generally not the cause for whatever symptoms that prompted the ordering of TSH in the first place. So just because a child has TSH elevation, it doesn't mean it is the cause for all the patient's problem. Patient may have an unrelated problem which is not related to TSH. So just because TSH elevated doesn't mean it's the cause for obesity or short stature. Generally, it's not the cause. So look for other causes. And TSH elevation is a consequence rather than cause of obesity. And mild TSH elevation generally remains stable or reverts back to normal in many patients. And there is a very low risk of overt hypothyroidism. So this quote holds good for subclinical hypothyroidism. The art of medicine consists in amusing the patient while the nature cures the disease. So most of the subclinical hypothyroidism reverts back to normal. So you have to just keep the patient on follow-up. Thank you. Thank you.